USMLE-style question on Guillain-Barré Syndrome, GBS. Question. A 32-year-old man presents to the emergency department with progressive weakness in both legs for the past 4 days. He describes a tingling sensation in his feet, which later progressed to difficulty walking. Over the past 24 hours, the weakness has ascended to his thighs and arms. He denies fever, rash, or trauma. 2 weeks ago, he had a mild diarrheal illness that resolved on its own. On examination, decreased deep tendon reflexes, DTRs, in all extremities, symmetric weakness in the lower and upper limbs, no sensory loss, normal cranial nerves and cognition. Lumbar puncture shows elevated protein 110 mg/dL, normal WBC count, 0 cells. Which of the following is the most likely mechanism of this patient's condition? A. Autoimmune-mediated demyelination of the central nervous system, inflammation and demyelination of peripheral nerves due to molecular mimicry. C. Endoneurial inflammation due to vasculitis of small vessels. D. Mutations in myelin proteins leading to progressive peripheral nerve dysfunction. E. Toxic neuropathy caused by bacterial neurotoxin inhibition of snare proteins. Inflammation and demyelination of peripheral nerves due to molecular mimicry. Explanation. This patient presents with rapidly progressive, ascending weakness with hyporeflexia, which is characteristic of Guillain-Barré Syndrome, GBS. The history of a preceding diarrheal illness, most commonly Campylobacter jejuni, suggests a post-infectious autoimmune response leading to immune-mediated demyelination of peripheral nerves. Key features of GBS: ascending and symmetric weakness, legs, arms, face in severe cases, hyporeflexia or areflexia, may progress to respiratory muscle weakness, requiring ventilatory support, autonomic dysfunction, arrhythmias, BP instability, urinary retention, pathophysiology, autoimmune destruction of Schwann cells due to molecular mimicry, antibodies against bacterial LPS cross-react with myelin and peripheral nerves, demyelination of motor and sensory peripheral nerves, conduction block, weakness. Diagnosis: CSF findings, elevated protein with normal WBC count, albuminocytologic dissociation, electromyography, EMG, slowed nerve conduction velocity due to demyelination. Treatment: plasmapheresis or IV immunoglobulin, IVIG, speeds recovery by removing autoantibodies. Supportive care: monitor respiratory function, FVC, cardiac stability. Why not the other options? A. Autoimmune-mediated demyelination of the central nervous system describes multiple sclerosis, MS, which affects the CNS, brain, and spinal cord. MS presents with relapsing remitting neurologic symptoms, optic neuritis, and MRI findings of white matter lesions, not peripheral nerve involvement. C. Endoneurial inflammation due to vasculitis of small vessels describes vasculitic neuropathies, e.g. in polyarteritis nodosa, which cause patchy asymmetric mononeuritis multiplex rather than symmetric ascending weakness. D. Mutations in myelin proteins leading to progressive peripheral nerve dysfunction describes hereditary neuropathies like Charcot-Marie-Tooth disease, which presents slowly over years, not acutely. E. Toxic neuropathy caused by bacterial neurotoxin inhibition of snare proteins describes botulism from Clostridium botulinum toxin, which causes flaccid paralysis, diplopia, and bulbar palsy, but preserves deep tendon reflexes. Take-home point: Guillain-Barré Syndrome, GBS, is an autoimmune disorder causing acute ascending weakness due to demyelination of peripheral nerves. It is often triggered by infections, e.g. Campylobacter jejuni. CSF shows elevated protein with normal WBC count. Treatment includes IVIG or plasmapheresis. Would you like a follow-up question?